So good afternoon and welcome to this Abbott-sponsored session that is about optimizing self-expandable TAVI clinical outcomes without compromise. My name is Nicolas Dumonteil and we'll be together throughout this session with Simon Redwood, Mariana Adamo, Joel Keffer, Leonard Conradi, Thomas Pilgrim, and Dr. Iqbal Malik. And you will see basically the session is built around a practical recorded case of a patient that was treated by Dr. Iqbal Malik in his center. And we'll mainly focus the discussions about those three objectives to optimize the TAVI patient outcomes from initial access, optimal implantation to the closure, to learn about the valve selection algorithm for the index procedure, but for the rest of the lifetime management of a patient, and also, of course, to learn how to optimize TAVI procedural workflow to optimize our resources. So I think, Simon, you can say a few words to our colleagues sitting in the room about how they can interact before we start.
So thank you. Thank you very much for the introduction, Nicholas. So as you'll see, there's some microphones throughout the auditorium if you're brave enough to stand up and ask any questions. If you'd rather the questions be anonymous or any comments be anonymous, please submit them via the app, and they will come up here on the laptop in front of me, and we will ask them at times when we can. And we will do our very best to address everybody's comments if we have time.
Thank you. So, Iqbal, maybe you can present us the patient you've treated and will use for that session.
Lovely. Well, thank you very much for the invitation to talk. And this is a fairly standard TAVI patient in our center. So 77, female, and on an echocardiogram, the gradient peak of 78, velocity more than 4:1 with good LV function, is a fairly straightforward TAVI patient. The symptoms, she's awaiting knee surgery, and that's why it was actually picked up in the first place. But when you talk to her, obviously she's limited by her mobility, but she is breathless up the stairs in any case. So she does have severe symptomatic aortic stenosis. The only unusual comorbidity she has is that she's got a non-functional left hand from a procedure many years ago at another institution. I think there was extravasation of some chemical into her arm, which led to probably a compartment syndrome, which led to a non-functional left hand. So she's very wary of medical procedures. So we should obviously do a CT scan, and I can document maybe that it's like a form fruste of a bicuspid valve. It's a tri-leaflet valve with 3 sinuses, but if you look, then the right and the left cuffs have just got a tiny bit of fusion, and you know that's recognized now. And then if you're looking at the 3D, you should really look all the way up, not just the leg axis, it's generous, it's straight, but actually right at the top, and as it turns again, focus on this. That's quite a sharp bend at the top end, and sometimes that obviously causes problems. It's very easy on 3-Mencio to predict the 3-cusp view and also the cusp overlap view, which is the way we'd want to deploy as high as possible to reduce the pacing rate. Sometimes, and probably in about 30% of my cases, the caudal is so extreme in RAO that I just can't achieve it, even with some contortion of my body. But this, with a caudal of 47, is just about the limit of what you might be able to achieve. And if the patient is horizontal on the CT and horizontal on the cath lab table, then the angles should be equivalent. So a calcium score just about 1100. So below the 1200 you might want for saying it must be severe aortic stenosis. But this is not grey. She's symptomatic and the echo says severe aortic stenosis. There's no LVOT calcification. Coronary heights are more than 10 and therefore reasonable. The perimeter and the area, I am a perimeter guy. There are some area guys, but I'm a perimeter guy, would fit with pretty much most technologies, a 23 Edwards, a 26 Medtronic, a 25 Navitor, and the sinus of Valsalva and the ST junction don't show any particular problems.
So thank you, Iqbal. So again, feel free to ask questions if this patient speaks to you according to past experience or to your practice. Maybe looking at this clinical history, one question to you, Mariana. In your practice, patient with AS, potentially asymptomatic with an indication of non-cardiac surgery, what do you do?
That's a great question, and sometimes it's tricky to decide. I mean, it really depends on the patient profile, on the patient characteristics, and on the risk of the non-cardiac surgery. Let's say so if the patient is truly asymptomatic, because sometimes we have also to understand if there is there are symptoms. Also using maybe natriuretic peptides dosage, this could be helpful in this. But in any case, if the patient is asymptomatic, you have to evaluate the risk of the intervention. If the intervention, then the non-cardiac intervention is at high risk, and or if the patient has a very severe aortic stenosis, or a high-risk profile like left ventricular dysfunction or pulmonary hypertension, you can decide to perform, of course, a TAVI before the non-cardiac surgery.
Okay, very clear. Lena, let's play the game of a heart team discussion here. We have the summary of clinical history of this patient in mind, 77-year-old female, apparently a low risk for surgery. So what would you say in your heart team weekly discussion? Would you go for TAVI or surgery in such patient?
Yeah, I guess, I mean, she's 77, thus even by the more conservative European guidelines, she falls into the TAVI scheme. That's one issue that I would absolutely respect. Second is that she seems to be somewhat impaired with mobility, right? Because she has knee problems or orthopedic problems that need to be addressed. And thirdly, there seems to be some suggestion of patient preference with that bad experience she's had with that arm. So I think these are three very good reasons to offer her contemporary TAVI.
And maybe to come back on that 1 second, what is nice in the presentation Dr. Malik gave us is that, and I think it has to be done like that in our heart team meetings, they analyze the CT scan and the anatomical characteristics of a CT scan to decide on the anatomical feasibility or anatomical risk of a transfemoral TAVI before to take any decision.
Absolutely, yeah. So what we try to do and achieve nowadays mostly is that we work the patients with aortic stenosis up in something that you could call a therapy agnostic way. So all of them should receive naturally an echo, maybe a TE if in doubt, but for sure all patients should receive a CT. Regardless of what their age is, even for surgery, this is very, very valuable. I think indispensable almost. And for these patients, of course, access evaluation is crucial to determine the therapy.
So now progressing in the discussion of how we could treat this patient, you've understood, of course, without disclosing any secret, that we're going to see a patient treated by Navitor. Joel, I think it is a patient that falls into the category of a small annulus patient. Your views on the compatibility of this kind of anatomy and the Navitor platform, is it a good candidate?
Yes, but you know, usually small annulus is occurred in the woman patients, and woman is a very, very good candidate for TAVI as compared with surgery in general, as demonstrated in the RHEA trial, for example, using balloon expanding valve. But the risk of using balloon expanding valve with small annulus is the risk of patient prosthesis mismatch and high residual gradient after a successful TAVI. So this is the reason why self-expanding valve is probably a good device selection for small annulus, and the tubular or cylindric shape of the stent frame of the Navitor is really useful to reduce the risk of patient prosthesis mismatch and residual gradient after the TAVI, specifically in small annulus and women. So I would suggest to select an intra-annular design and a tubular shape stent frame for reduce the risk of residual gradient after the TAVI.
Yeah, thank you. And again, I'm diving a little bit more into the procedural planning or all what we do before to plan such procedures. Thomas, looking at the sizing we saw, and maybe Iqbal, you can come back on the measurements just to remind everyone what you had. We could say we are maybe at the lower end of a sizing chart for Navitor 25. So where you are when you are in gray zones between two sizes with a Navitor platform, what is your experience?
Yeah, I think that's a very important question in clinical practice. So I mostly rely on perimeter-derived annulus diameter in patients treated with self-expanding valves. But it's not only about the annulus, it's also about maybe a degree of calcification. If there is severe calcification, I would maybe rather opt for a smaller device. Also about LVOT diameter, maybe. If you have an LVOT that flares, you may be happy to implant also a larger rather than a smaller valve. It's about diameter of the sinus of the ascending aorta, maybe about ellipticity. So I think there are several parameters that we can factor in this decision.
Yeah, thank you. So, Simon, just again, Iqbal, if you can come back on your scrolling on the CT. You mentioned that looking at those leaflets, one might have a feeling that it's a kind of bicuspid anatomy. What's your opinion on that? Because it can have some consequences of your procedural technique.
I think so. I mean, it's not a true bicuspid. There are 3 cusps there, aren't there? And I think as long as you get adequate predilatation, I think it should be perfect for a Navitor. And the other thing that hasn't been mentioned yet is that her coronaries look normal just on these little snapshots we see here. But I think it's important to maintain coronary access, particularly in someone of this age who's likely to live for another 15 plus years, I hope, just in case she has future coronary events. So Navitor would be ideal.
Okay. So, yeah, if we summarize, we have, I think, quite an agreement and an obvious good indication for transfemoral TAVI, and an overall aortic root anatomy, which makes totally sense for the choice of a Navitor, both from a valvular performance and also for a potential coronary access, and we'll see many events for the future. Maybe, Iqbal, before we go to your case presentation of the procedure, one question one might have in the room, and at least I have, in my practice, during the pre-procedural screening, we still routinely perform coronary angiogram. So we didn't see that here. Is it something because it was normal, or you don't do it?
We actually don't do it. So Chris Cook from the UK published a study which looked at how often that stops you doing the TAVI, and it's very, very rare when the CT's cleared the proximal LAD, the left main stem, the proximal right, so which is clear in this case. If we see possible left main stem disease, we'll do an angiogram in advance. But otherwise, I'm not really targeting the coronaries. This is not chest pain presentation. She's breathless. She's got severe symptomatic aortic stenosis. So as I've gone older, I've become more conservative in coronary intervention and more aggressive in TAVI intervention. So you'd have to twist my arm to put a stent into her, even if there was a narrowing in the mid-LAD. So we do not routinely perform an angiogram in advance.
Okay, thank you. Very clear, but let me just elaborate a little bit with you on that also, because again, thinking of my experience, I sometimes struggle a little bit with the quality of my CT scan to be able to assess potential, even proximal coronary artery disease. Here, what you showed was really, really nice as kind of images. So for me and our colleagues in the audience, any advice? Did you communicate with your radiologist about the protocol of acquisition to be able to analyze both the coronaries and the valve, or it's just because they are doing a good job?
So we're very closely linked with our cardiac radiologists. They're actually at our MDT as well. So if the pictures are not good, they hear about it immediately, and the feedback is instant. So those who know me will know that feedback is instant and fairly aggressive. So we've calibrated the service. So actually, the day I see the patient in clinic is the day they get their CT scan, which is highly unusual, especially for the UK. And then the next week, we've usually discussed it at the MDT, where the radiologist is there and a cardiac surgeon is there. So we've got the full MDT, and we've made a final decision about what we want to do. So no advanced coronary angiography. If the MDT feels we're not sure, we probably won't repeat the CT scan because they may still be blurry. But our CT quality is excellent. The only time is when there's a breath moving, and then the annulus is blurry as well, and we have to repeat it.
And when you have a doubt about the coronaries at the CT scan, what is your adaptation to that?
So then we'll do an angiogram in advance of the day if really I think it's prognostic coronary disease. It has to be prognostic. If I've got a doubt about the mid-LAD and beyond, I'm doing an angiogram on the day, which is what we're going to do here. Absolutely will not bring them to the table. There's been one patient ever that I've stopped the TAVI because of what the coronaries were doing. And that was someone who I was going to plan axillary access because there was no other access. So I did a right radial angiogram first. He had a critical right coronary lesion with breathlessness as the only symptom. So I said, look, 5 or 10% risk TAVI versus a 1% stent. I'll do the stent and see how you go. 3 years later, he's still got no symptoms. He's still got severe aortic stenosis. But it sticks in my head as a unique sort of case where a non-left main stem coronary anatomy led me to change practice. But that was only because the TAVI was difficult. If the TAVI had been a very easy TAVI, almost certainly I would have just put the TAVI in and seen how the coronaries were afterwards, and I don't know what would have happened. But this was a complex TAVI. So that's the only time I would actually, at the time of the angiogram, stop. I found a left main stem I wasn't expecting, which is rare, or I found a very tight lesion, but the TAVI is complex and the stent is easy. So the lowest risk thing for the patient is to try the stent first.
And maybe last question to you, Leonard, and before we proceed, as the idea is to discuss about what is happening before the TAVI procedure. It's discussing about the TAVI workflow. Do you think you can adapt what Dr. Malik presents for the situations of patients being at low risk for aortic valve replacement? High risk for coronary artery disease, diabetic, I mean, for example, for which the evidence of complex free vessel coronary artery disease could change your decision from an indication of percutaneous approach to surgical approach. What is your practice?
Well, yes, the answer would probably be yes and no. So I find myself asking less and less for coronary angiograms, especially in patients that are at low risk for coronary disease. Of course, say, imagine mitral patients who would undergo endoscopic mitral valve repairs. We stop doing angios altogether because they receive CTs anyhow for access planning, rule out of valvular calcium on the mitral annulus and these things. If there's no coronary calcium, we don't proceed. If there is risk, like you say, a youngish aortic stenosis patients with some risk profile, we still are conservative and would ask our colleagues for an angio.
Okay, thank you, very clear. So let's now discover how you treated your patient.
Okay, so we're going to use a 25 Navitor, and she's young, and as Simon says, coronary access is going to be important for the future because she, despite her left hand, she's actually a survivor, and I think she will survive, who knows, but probably to 90. And so if she survives to 90, we are going to be thinking about coronary disease in the future and also revalving. So intraannular leaflets, big cells, I think all of that, active sealing. And I want to highlight the very clear markers because that will allow us to judge the height, if not the alignment, at least the height of the valve that we're putting in. So we're going to do right femoral artery as the main access. We put 2 ProGlides in. I know many centers now do 1 ProGlide and angioseal. That's absolutely fine. We tend to put 2 ProGlides in. I'm going to try and go sheath less for the valve. That's what we almost always do. The other access is certainly not in her going to be the right arm. She's only got 1 dodgy hand. I don't want to give her a second dodgy hand, however low the risk is. And the femoral access is absolutely fine. I must say, we always put in a femoral venous sheath, under ultrasound guidance, obviously. That, number one, allows me to put a wire into the right atrium as my pacing, so Safari and a wire in the right atrium. I know people do skin pacing. I found it less effective. I don't know what I'm doing wrong, but I find it less effective, so I've always put a wire in. We also, just to say how we do TAVI, have an anaesthetist in the room. The anaesthetist is giving intravenous paracetamol, which is amazing. It's like morphine. I give local anesthetic, and the calibration of sedation up and down for us is not the nurse, it's the anaesthetist. And the anaesthetist I'm very friendly with. There are some hospitals who can't find an anaesthetist. That's not the situation with us. It's an easy day for our anaesthetist when it's a TAVI list, because they're only there really to mop up when the patient gets very uncomfortable. Otherwise, they're having coffee, checking their emails. Is that a waste of resource? I don't think so, because I'm very comfortable with it. And also, if something happens, they're right there. There's no call the crash team. They're right there. So I like it that way. And actually, that gives them an access so they're not fiddling about putting central lines in. No urinary catheter, no central line in the neck, no formal temporary pacing wire. But I do 2 accesses, not a single access procedure. The angiogram is going to be done on the day. The aortogram is done with a pigtail in the non-coronary sinus and an AL1 catheter in the left coronary sinus. No pump injections. It's 5 mils into each. We'll show you what you need to see. And then we're going to balloon up front via a 14 French Cook sheath. So I've upscaled from the 6 put true proglides in to a 10. Then once I'm across with the Safari, we're going to put in a 14 French sheath so we can do a balloon valvuloplasty. I don't invariably do a balloon valvuloplasty, but we did it in a particular case, and then we can discuss the sizing. So let's see what we did. Okay, so that's the smaller access, 6 French, above the bifurcation. Next. And this is the larger access, and we can see a very good puncture done under ultrasound guidance, and we'll go from there. So we're at the next stage of the procedure, and so we have done a coronary angiogram. And so if we play through the images, so this is the left coronary artery, and we can see perhaps a little bit of disease in the circumflex as it goes down. Next shot, please. And then as we do the cranial shot, we can see that the LAD is okay, but the ostium of the diagonal has a pinch. Next shot. And in the right coronary artery, there's a suspicion that the PDA origin may have some disease. Next shot. And that's shown up by the cranial view. Okay, so let's show the next angiogram. Okay, because then what we're going to be doing is to line up in the 3-cusp view, and you can see clearly that 3-cusp view is correct. We predicted it on CT scan. We do our own 3-Mencio analysis. This is not a pump injection. This is 5 mils into the pigtail, which is in the non-coronary sinus, and 5 mils into the AL1 catheter, which is in the left coronary sinus. Next shot, and next shot. Right, and this is the 2-cusp view, the cusp overlay view, so the left and right are overlying each other, and the non-coronary sinus is on the left-hand side of the picture. So if we look at the hemodynamic screen, we can see that the LV pressure is about 180 with an EDP of about 7 or 8, and the aortic pressure is 130, and the diastolic pressure is 64. I'll rotate. Oh, that looks nice. Okay, stop there. So I don't see any problem with that. We're at the stage of balloon valvuloplasty. It was 19 as the minimum diameter, so we're using an 18 balloon. Let's screen. Okay, I've got the wire. So I'm feeding up on the wire. Now Neil's got the wire. He can control everything. And I think I always find that one person controlling both the wire and the balloon means it travels in the way you want. 2 people doing it, perhaps not so elegant. Okay, it's coming. Feeling a bit stiff, is it? Okay, so that's actually very good.
Yeah, so pacing on.
Okay, 180 there.
Yep, balloon up. Yep. And down. We got it there. Pacing off.
Pacing off.
We got it as it expands as well.
Now we can see the ECG has changed slightly to a bundle branch block pattern. So let's do the inflation. So it's caught. Okay, so I think we've caught it. Fine. So I don't think we need to re-inflate. So we'll take this back out.
Let's make a pause here and discuss about the initial part, the initial steps of a procedure.
The other thing to say is if you have any questions or comments, submit them via the app so that we can discuss things. Thank you.
Of course, and if you have any question to ask to Dr. Malik about that, but maybe one thing you could clarify, because it was not perfectly clear for me, is the way you pace.
Yeah.
Can you re-explain, please?
So we've got an external pacemaker box with them crocodile clips.
Yeah.
One wire is from the vein up into the right atrium. The other wire is a Safari wire. So the simple metric is the red clip to the right atrium, red to right, and the black clip is on the Safari wire. We've tested the pacing, and we know that we can pace with the amps turned up at 180 very stable, no loss of capture. Because obviously with the valve going in, if we were to pace and you have an ectopic at the wrong moment, that's a disaster. So especially with the balloon expanded valve. So this is tested in advance, but it's with clips.
But you mean that one of your electrode is the wire placed in the vein in contact with the right atrium?
Yeah.
But you need a catheter to isolate it, or
No,
just through the sheath, it's okay?
Just to the sheath.
Okay, yeah, interesting. Interesting.
Maybe a question regarding the size of the balloon for the predilation. So you have an annulus of 18 on 24 millimeter, and you select a balloon 18. Can you comment?
So again, because I'm not a great believer that balloon dilatation tells me very much, it's not a very heavily calcified valve, I'm not really trying to push it to the limit. And so, of course, that's me being silly, because if I was putting an Edwards valve in, it would be a 23 balloon, and we're all very comfortable with that. So I could have used a 20, and I think in a different day I might have done. The other thing, the balloon slipped slightly, but I think I've loosened it enough that it's fine. So I didn't want to do a second balloon run, because although the pressure only goes down for a short period of time, this is a completely conscious patient. I'm talking to her through this. And so if you do too many pacing runs, they become aware of it, they start rolling downhill, and then you're into a situation where sedation starts to escalate. So she is communicating, we've told her we're pushing in the groin, we've told her that she's going to get a bit dizzy, and that means that she is perfectly able to tolerate the procedure. If I get stung by a bee and I didn't know there was a bee, I jump. If I get stung by a bee because I could see the bee on my hand, I'm jumping less. It's the same with the patient.
So to summarize, you select the balloon size according
On the
to
minimum.
diameter, because there is not so much calcium in the valve and in the annulus. That's correct?
Yeah.
Maybe let's have a small discussion about that. You have a question, Simon?
Yeah, so I mean, the annulus is 18 by 24, and the current recommendation from Abbott is to use a larger balloon, probably the average of those two measurements. So we would be saying 20. I mean, I appreciate your comments, and I agree that it's not heavily calcified. But just to make that point, that perhaps a more aggressive balloon valvuloplasty might have been recommended. But I'm sure it's going to be fine in this case, to be honest.
Yeah, that was my point. Maybe it's something we need to discuss a little bit. I think what we've learned with the experience and with this platform is that in order to optimize the way it opens and the way it distributes the force once opening, the way we prepare the valve with balloon predilatation is crucial. And I used to do the same than you, and Iqbal, let's say downsizing the balloon. But what I do more and more is to go to this approach you summarize, Simon. In other words, using a balloon sized according to the mean diameter of the annulus. Is it what you do also, Joël, for example?
More and more. So 1 or 2 years ago, I start with minimum diameter, but then to optimize the stent frame expansion, I would say. So I am going a little bit higher diameter according to the mean diameter, or between the minimum and the mean. Yeah.
And I think the advantage of that is that the incidence of needing to post-dilate is much less because of inadequate expansion. Just to change the topic slightly, there was a question that I thought we had covered earlier on, was as why the actual question says, why have we concluded balloon expandable was a better option? But I think we concluded that self-expanding was a better option than balloon expandable. And for the reasons are, it's a small annulus, you probably get a better EOA, better hemodynamics, and because of the age, we want a valve which has good subsequent coronary access, and Navitor lends itself very nicely to that.
Okay, so let's now discover what was the rest of the procedure.
We're going to dilate up the tract, so I'll hold the wire.
Well done.
Okay, you're doing very well. So it's a straight run, so it should be fine, which it is. Super. So let's plan the next part, which is the valve. So the dilator is going to come out and the valve is going to go in. So are we ready for that? Yep. Okay, so I'll pull the dilator out. We're making sure the wire does not move out.
So let's go straight, PA, please.
We'll take a wet and we'll wipe the wire.
And just Safari at the top, please. Safari at the top of the screen. That's good, thank you.
Okay, so we are going to just have the port at 3 o'clock, and I'm holding the wire and just jiggling a bit. Again, let's change the height so that it's vertically downwards, and that should go through the skin. That's it. So I just felt it go through. So the angle's quite important, and now I'm going to get some negative pressure on it as the valve goes up. Here we go. Okay, so let's pause there. That's good. Right, so let's screen in LAO, okay, and see what it looks like. Go up, follow up, follow up, follow up. Okay, so we can, if I rotate, if we screen, yeah, you can see that the 3 markers rotate very easily, so that's fine. So let's hold in that view and we'll carry on. And I'm going to tug slightly because the arch is a bit tight. And we'll just let the heartbeat do the business. Go up a bit. Can you see? Hang on. Go up a bit. Go up a bit. Are you on mag? Are you on mag? Or are you off mag? Okay, so you can see that it's quite tight there. The arch, it's just about to go. That's it. Okay, so save that. Hold it. Save that. So there was some negative pressure on the wire, some gentle forward traction, a nicely sedated patient.
Okay, so let's go to the implant, grab that implant view. Yeah.
Okay, fine. So we've got our line in. There's a bit of calcification to tell us where to go. And so, yep, I'm happy. So you're basically advancing it in. Neil's doing all the work here to get it through and then into the right sort of height in the cusp overlay view. So if you're happy there, Neil, shall we take a picture?
Yeah. Yeah.
Okay, so I think that's looking good. The dots are there. Rapid pacing, yay or nay?
No,
I think not.
I think it's a very stable valve.
It's a very stable valve. So we're going to watch the hemodynamics. There's already left bundle branch block. And we're going to watch the hemodynamics. And I'm deploying while Neil is controlling the valve position. The pigtail's not really moving, which is great. I'll just push that down a tiny bit to lock it down there. And the dots are remaining where that calcium is, which is great. Here it comes. So it's drifting downwards, isn't it?
Yeah, it's fine. It's just moving a bit, so it's
Yeah.
to capture a bit.
So that's looking very nice. That height is looking on the money. Is that drifted a bit?
Sorry, you can.
And the pressure's down a bit. I'm just continuing to deploy. Has that gone down?
Yeah.
That's gone down a lot. I think we should just recapture that. We're not going to pull with that, so just hold still. So I'm just going to recapture. We won't do a full recapture. We'll just get it to around about there, and then take a quick puff of dye.
I'll push on the one.
Yeah, so you've done a slightly higher position, which is great. And I think that should lock it. Oh, that's looking much better.
So at this point, to keep it in position, you don't pull on the device, you push on the wire.
Yeah, it's definitely looking very good.
If you pull on the device, it
Putting
makes
some
it less
effort in there.
coaxial.
We've got to the hard stop there. Okay, so the heart rate has gone down a bit, but it's recovering. Is that complete heart block? It's bundle branch block.
Sinus, I think. No, it's sinus.
It's sinus. Okay, so that's fine. So we've got a very stable position. So let's acquire a picture.
Yeah.
Okay, so it's we probably want to align the bottom of the valves. In this view, can you go caudal? If you possibly can. You may have to raise the table up. You can't go anymore. Let's take a picture. Okay, so I think it's at the bottom of the calcium, which must be at the bottom of the leaflet. So I'm not sure that's a bad position. I don't think we want to probably recapture that. Yeah. So can we go to the 3 cusp view now? The 3 cusp view.
Yeah.
So before release, we should always check. Now, there's no crowding I can see on the frame there. Can you see any crowding? I don't
I think it looks pretty well expanded, but we'll get the orthogonal view, as you say, just to see.
So let's have a look at this view. And so let's align. So can we go caudal from there to align?
So maybe 40 caudal, something like that?
It's coming, it's coming, it's coming, it's coming.
Yeah.
Oh, that's very good. Okay, so let's take a picture of that.
Yeah.
Okay, so I think it's marginally lower than ideal, but I think it's acceptable. I'm not sure I want to recapture this, especially because for her, revalving and coronary access are probably more of an issue. So I think it's well expanded. Yeah, okay, so you can see that's the view that would show us the left coronary artery, and I think it's not unreasonable. So I think the height's reasonable, I think alignment is reasonable, not that we can control it very much, and I think I'd be ready to deploy this valve.
And expansion is good.
And expansion is good, exactly. So I'd be very happy to deploy this valve. So we'll press the button so that we can then continue to release the valve. And we're keeping an eye that I don't think it's going to move, but keeping an eye. And then we'll repeat our pictures before we pull the pigtail back. Now, some people would pull the pictail back now. I don't think there's any danger with that pigtail particularly. I think I wouldn't. That's not our standard. We don't normally do it. And so I think we'll just stick with our normal pathway.
And here, I mean, I'm very neutral.
Yeah. So I'm deliberately doing it nice and slowly. One still attached. Yeah. And one still attached. And there it's pinged. And that's taking its shape.
There's just one port still, isn't
And there we go. That's the last one out. Okay, so save that, please. Okay, superb. So, Neil, talk us through retrieving the capsule.
In a three-cuss view, by just pulling back and withdrawing the stiff wire, you can see that you can see there the nose cone centralizes. And if we now go to the cusp overlap view, the kind of very steep areocaudal, please.
That's great. So Neil's milking out, and I think both Neil and I like to have full control of both the wire and the nose cone when we're doing this. So Neil's probably going to advance the wire now to just get it back into the ventricle. There it's taking a beautiful shape as it goes into the ventricle, and the nose cone has drifted itself out. We always want to get above the valve frame completely to be sure. Okay, so some rhythm disturbance just with our wire. So I'm going to press the two blue buttons and draw back. And Neil's feeding the wire. And you can see there's no rush. We're just going to get the nose cone back on top of the catheter. There we go. And I'm hoping that it'll settle itself down. We've got a couple of pictures to do and some hemodynamics to do. But the case has gone actually very well. We've done sheathless because we don't want to enlarge a hole. We didn't need to enlarge the hole. And you can see that obviously slips in perfectly easily given the valve's been through there. Big flush syringe, please.
Yeah. Do a pullback then, yeah?
Yeah, do a pullback. And again, I screen this all the way out. Ready? So I'm actually more looking at the height, which I think looks very good. Mrs. Baines, you're doing very well. Hold nice and still. Hold nice and still. And then we'll push the first one down. So there's a slight pinch at the puncture point, but there's normal flow. So, and there's no hematoma developing. So I'm very comfortable with that. JY, please. Okay, so that is the angioseal going in. Neil, congratulations. Okay, a very successful case. My thanks to Kat and the Abbott team for supporting the case, and I look forward to showing you our next one.
So thank you. I think they're very interesting procedural points because TAVI being now very popular globally, I think, and we all have some common aspects of the procedures, but some small differences, and we saw some here. Maybe I would have one question, something that you should maybe clarify for the audience and for a colleague at a point. Once the valve was deployed, you mentioned that the frame, you said that it was not crowded, the frame was not crowded. So can you explain a little bit more about what it means?
Sure.
And what you had in mind?
Okay, fantastic. So to summarize what we were trying to achieve, not too lower height because that would increase pacing, not too higher height because that might lead to a valve pop-up and actually make coronary access more difficult, which we'll come to at the last part of this presentation. And then when we're deploying the valve, we're looking at the height, but we're also looking at the crowns that are all along the bottom of the frame. And so if we can see all of them are evenly spaced around the annulus, then there's very little chance of extra tension suddenly arriving and the valve popping upwards later. If in fact there's some crowding on one side, so the crowns on one side look wide open, on the other side they're all close together, all the peaks are close together, then something's not quite right then. It's probably that the valve hasn't fully expanded there. If you've got a very high valve in that situation, I'd probably recapture and put it lower because there's more tension than I would want. If it's a lower valve and I don't want to move it again, that might be one where a balloon might be needed just to push those crowns out a bit further.
Okay, very clear. Thank you.
Iqbal, there's a comment or a question from the audience on that note as to why you didn't post-dilate it, because the frame geometry seemed a bit underexpanded. And on that note, I missed actually, what was the gradient and the EDP?
So the gradient at the end was 0. It'll come in the presentation, 0 and 0. The EDP hadn't changed. And it allows me to make the point about coronary perfusion pressure and AI index, because we actually do hemodynamics on every single case. And we do an echo in the lab on every single case. And the reason we do that is I'm always paranoid about leaving any degree of aortic regurgitation behind, because then that drops my coronary perfusion pressure. So in her, the coronary perfusion pressure before and after was entirely unchanged. The AI index, if you divide the gap between aortic diastolic and EDP by the systolic aortic, you get the AI index, was unchanged. So we've cured her aortic stenosis, but and not reduced her coronary perfusion by leaving a lot of aortic regurgitation behind. Now, as soon as we did the BAV, she already had left bundle branch block. She was actually planned as a day case TAVI, so she's coming in the morning and the plan is to get her home in the evening. As we know, putting in a pacemaker loses some of the benefit that you gain from TAVI because the coordination of the ventricle starts disappearing. We don't know yet whether bundle branch pacing and things will be a solution to that. So there isn't a significant amount of AR, both on the echo, both on the hemo. I think the valve looks, it's an oval annulus, so it will look oval, but I'm not thinking this is very underexpanded. And a self-expanded frame will expand a little bit more in any case. So I don't want to put a pacemaker in, and therefore I don't think there's a need for a post-dilatation here.
Okay, and you demonstrate during this deployment that you didn't need to pace to have a stable valve, especially during the inflow opening. Do you have any criteria to decide whether you need to pace with a navigator or not, depending on the heart rate, on the any kind of yo-yo movement, on an amount of AR?
Yeah.
Or you just try first like that, and if it's unstable, you pace?
No, I think if we're putting a very large valve in, then we want the maximum control the first time. If, in fact, I'm seeing there's a lot of ectopics, and I've had cases where the ventricle is just very irritable, then I need to control that because I just don't have a stable platform. And so those are the two. And if the valve is actually moving up and down a lot, but for whatever reason, then creating stability by pacing probably at about 120 would be fine. Obviously, for balloon expanded valves, we pace at 180. I've had to pace at 300 in one of my latest balloon expanded valves because the ventricle was just so aggressive that the pressure wasn't dropping. But here I don't want the pressure to drop. It's a conscious patient. And I've got a very stable deployment. The first one slipped down a tiny bit, but as you saw, the hemodynamics weren't catastrophic. I've just partially recaptured and we redeployed using the calcium actually that was at the bottom of the leaflet as the marker. So if you looked at the pigtail, it might look slightly low, but if you looked at the calcium, it's pretty reasonable deployment.
Okay. So in case we don't have any more, yeah, you have.
I would like to ask you to expand a little bit on the access site. So if you have a failure of the access, how do you manage it, and which kind of device do you usually use?
Okay, so one of the reasons we always have two arterial accesses is because sometimes you can't tell you've failed. And so I know many centers are too busy to do even an angiogram or anything for the other leg. I'm not that busy. Okay, I can do 5 in a day, but I still want to do it the way I want to do it. So I'll always do a leg shot at the end. And I've had cases where the patient is awake, completely asymptomatic, and the leg is totally occluded. And I've had cases where there's continuing oozing, which hasn't yet demonstrated a problem, but on the ward in an hour's time it might. So if it's a slow ooze, then, and I've already pulled everything out, then I'm going to compress over it, often with an ultrasound, so I know where I'm compressing, wait 10 minutes and check the picture again, because I've got a contralateral pigtail taking the picture. If it's clearly a disaster, then I can cross from the other side, upsize that 6 French leads to a 10 French, cross over, and then usually you need a Terumo or something to cross, change over to a stiff wire so you can go around the bifurcation and down, and we've got covered stents available in the lab. So us as cardiologists are very used now to bailing ourselves out with a covered stent rather than calling interventional radiology. We started in our hospital calling our interventional radiology friends. They got a bit bored with us calling and eventually said, you don't need us, you know what you're doing, so we can bail ourselves out. And we also have a vascular surgeon who's available if we really can't bail ourselves out and we've done something catastrophic, and then they can come and, in the lab, just open the leg up and tidy it up.
So now carry on with this patient journey. Can you tell us a little bit about how this patient was discharged and your global recommendation for patient discharge in your institution?
Okay, so you can see the hemodynamics here. They're excellent. They're good dicrotic notch, good coronary perfusion pressure. And there is one publication that you may have seen comparing the AI index before and after the TAVI. And that publication said, look, it can change. If you're treating aortic stenosis, it's often be less than 1. So the before and after dividing each other will be less than 1. But if it's above 0.6, you're probably okay. So there's one publication which says that. I've shown the data here in case you're interested in that sort of ratio. We don't routinely calculate the AI ratio as long as the coronary perfusion is unchanged and the AI index is okay. So the TAVI was successful. All my patients get a 4-point check. So we're checking the ECG, we're checking the echo, we're checking the groin, and we're doing fast. So I need to know they've not had a stroke on the table. If we send them out, then we're planning to try and get home the same day if the bundle recovered. Then they get another 4-point check pretty much every hour, not an echo every hour. They'll get one echo before they go home. But the 4-point check is something that I've trained all of the juniors, all the nursing staff to do. ECG check, echo check, leg check, and a stroke check. So let's imagine that all of those were successful. The ECG is back to baseline, the echo's fine, the leg's fine. Our mobilization protocol is they leave the lab at 30 degrees. 1 hour later, they're sitting up in bed at 80 degrees. 1 hour later, they're sitting in a chair next to the bed. 1 hour after that, they're walking around off the monitor to make sure they can mobilize. And our day case protocol, the criteria is a straightforward femoral TAVI. They've either got a pacemaker or a normal ECG when we start. And more importantly, they've got social support at home. If they've got those 3 things, we want to do a day case TAVI if at all possible. Because the left bundle did not get better, and because she's actually had a new left bundle branch block, I wasn't bold enough to send her home immediately. She went home. This was Monday's case, this Monday. She went home Tuesday morning. She's still got left bundle, but I'm happy with that. We're running a trial at the moment called TAVI, where we're really trying to push the boundaries. So they either get a trial of home monitoring to make us a bit more comfortable going home, telemetry that goes to CCU, or we decide what to do without the home monitoring to see what happens to these patients even when we do send them home. So we don't have the results of that as yet, but she went home at 24 hours. Aspirin is the treatment.
Thank you very much. So now for the last part of this session, let's reflect and discuss together on the future. We've seen how and what we do before, and we discuss how to optimize things. We've seen the procedure, how to optimize the procedure to optimize the outcome we have for the patient. But here is a reasonably young patient, but not extremely young. But we know that we need to optimize a substantial number of things for short-term, mid-term, long-term consideration, especially for long life expectancy patients. So different aspects related to that, Mariana. Maybe coming to what we know about the long-term valve performance of this platform. Can you briefly summarize what we know currently?
Yeah, we have recent data published last year, presented last year at CRT. It's a pooled analysis of a randomized control trial and a registry, more than 1,000 patients. It's not published yet, but it's going to be published soon, hopefully. is the old platform, is the Portico platform, but the results are real promising because we have a rate of freedom from structural valve deterioration, which is 99%, so very, very high. And the rate of bioprosthetic valve failure is about 3%, even if we consider the events which are related with a reintervention or with a death, is close to 1%. So really promising results that show a long durability of this valve at 5 years.
Okay, so thank you. Joël, another aspect related to this, to those considerations we need to have in mind for future management is the access to coronary arteries. This patient didn't have significant coronary artery disease, but others can have. So what can you tell about your experience of coronary reaccess through Navitor?
Yes, but coronary reaccess is so easy with short stent frame, but in case you use a longer stent frame, it's important to think about coronary reaccess for the future and using a stent geometry with larger cells is for sure useful for allowing a reaccess of coronary ostia. And the position of the leaflet as well is intra-annular, so below the coronary ostia. So it's really helpful to re-engage the coronary arteries in the future.
Okay. Thomas, I think we had a question coming from one of our colleagues in the audience about that. Is it feasible to obtain good commissural or even coronary alignment with this platform? Because we know it can have some impact also on the future considerations.
Yeah, I think that's a very good question. So the dot markers this valve has certainly been designed to determine the optimal height of implantation, but they can also be used to get a commissural alignment. So it's maybe a little bit hard to see the dot markers once you advance the catheter across the aortic arch, but if you see the dot markers in the LAO projector, 2 dot markers on the right side of the screen in the LAO projector, you should be fine. Then you go for a cusp overlap view, and then you should see 2 dot markers on the left-hand side, 1 on the right-hand side, and as soon as you start to release the valve a little bit, you can determine whether you're in optimal commissural alignment.
And that's exactly what we saw actually from the video. I don't know if people noticed it. The other thing to say is if you don't see that, you should pull the device back to the descending aorta to turn it, rather than try and turn it in the ascending aorta. That makes sense.
Leonard, thinking about potential revalving, again here maybe if we think about epidemiological data, a patient who is 77-year-old, maybe it doesn't have a high probability for the need of revalving, but in a more global discussion, let's say when we have our heart team discussion, of course and we'll come back to that with Dr. Malik, we try to anticipate what could be the option for a redo TAVI. But in the mind of heart team members, we need to know also what is the risk for a patient of redo a surgery after first TAVI. So can you summarize briefly what we know about this?
Yeah, so I think most heart teams would agree that we would like to opt for a procedure that is the one and only for the patient, so come with a good initial result and serve the patient for life, but still, as we come down with age, we're considering valve failure and how to deal with it. And of course, there are many factors influencing revalvability, some patient-related, some device-related. And we think someone talked about short stent frame. This is probably beneficial to a long stent frame, but the valve position in itself plays a role. And I think intra-annular is probably, in general, more friendly for revalving. I think this valve particularly is probably well suitable for revalving, especially since it's maybe slightly lower than it could be. Naturally, we need to do a CT. That's probably common sense by now, that we need to re-scan the anatomy because it might have changed, and we need to assess many of the standard factors that we do. And then finally, if you do opt for valve explant, I think the discussion nowadays is mostly dominated by, of course, by what we have right now in terms of data on TAVR explant. And this is, in a way, probably not the kind of target population that we might see in the future. These are now elderly, high-risk patients, a high rate of endocarditis patients, patients with severe comorbidities. Probably the patient profiles of patients needing valve explant is going to change in the future, right? Because we're treating more younger, more healthy patients, and in the future the rate of those that need to be explanted more for anatomical reasons, right? So at present it is a high-risk procedure that I think we should prevent by all means. In the future, I'm not so sure.
Okay. And maybe to finish with that, Iqbal, when you have a patient who has a life expectancy making possible the need for revalving, how do you anticipate that from the first CT scan to guide the choice of your first TAVI device? Can you go through that maybe briefly in 1-2 minutes?
Yeah, so let me use the presentation for revalving. First of all, you need to know what you've put in. And so in particular, what the height of the leaflets are. And for this valve, it's 23 millimeters. So if this valve is put in with the dot markers, we've probably taken 6 or 7 millimeters out. That's still about 14 millimeters. And the coronary heights, remember, 10, 11. So what we're going to try and say, look, you need a new CT, as Leonard said. And we need the original CT to know what it looked like, what was the annual sizing, and we need to know what TAVI valve was put in. And so if you then do that, you're going to try and assess where the nodes are on the old valve that is now in there, and you're going to assess the alignment because if you want to do leaflet modification, alignment with the coronaries is very important. And of course, there's alignment with the commissures and more importantly, alignment with the coronaries, as the point's been made already. We need to know that the coronaries have a leaflet in the way if we're going to leaflet modify, because if there's a post in the way, no leaflet modification will really help. So that's why I think increasingly, as we get a younger population, trying to align, as Simon pointed out, we actually achieved a pretty reasonable alignment in this case. Is going to be more and more important. So here's a sort of stepwise way. I would almost invariably put a short valve into this tall valve. I just can't get my brain into thinking about a tall valve inside a tall valve. It's too much to think about. So let's talk about a short valve in a tall valve. So we confirm the index TAVI, it was a 25 portico. We identify where is the coronary risk plane with the repeat CT scan. We selected a short valve. And then we decide where we're going to implant. And of course, if it was an aortic regurgitation failure with very thin pliable leaflets, you could go a bit lower and save your coronaries because the leaflet overhang won't matter as much. But actually, if you've got aortic stenosis, if you leave leaflet overhang, you might actually leave the stenosis behind. So the mechanism of failure is also important. So there's the concept of the coronary risk plane, the height of the coronaries, the lowest coronary being most important, and the neoskirt plane, because if I jail the old leaflets out vertically, we know where it's going to be. It's going to be at the bottom of those little silver tabs. So what about the size that we're going to put in? Because it's not necessarily the case that the size that we're going to put in was like it was in a bench. So we've got the CT and we can look at the actual sizing at each of the levels of height to finally make a decision about whether this is a low-risk procedure, where the coronaries are just not in jeopardy, especially if the coronary risk plane is higher than the neoskirt plane. Or if the VTCs are very generous, there's no sinotubular junction problem that might produce sinus sequestration. So revalving is not straightforward. A short in tall, I think, probably is a better bet. And I think we do need to be able to look at how we might leaflet modify in an aligned valve.
I don't know if we've got time, but there's one very final quick question about coronary access with Navitor compared to Evolut FX. And with the current generation Evolut, I think that my feeling is that the cells are much smaller, and so it is a bit more difficult. It's still possible, but you have to use a few extra tricks, like using a guide liner. But I think we're probably just about on time, aren't we? So we go to the very last slide. So I'm just going to summarize. I think this has been an excellent session. It was a very good case. Thank you very much, Iqbal, and a very good discussion. And we managed to cover a lot of good points, and there's been a lot of points that we've also managed to cover from the audience. So thank you for your interaction. But I think to summarize, I would say the key learnings are we need to think about lifetime management, and we need to plan for the patient's future at the outset. So you need to take all these considerations into account: the age of the patient, how long they're likely to live, whether they're going to need a second valve, when you're choosing for your first index valve, which is incredibly important. And obviously, when you do the procedure, you want to make sure you're optimized it, which we've seen here with a lack of gradient, with no aortic regurgitation, and obviously patent coronaries, and a good, successful procedure. So I'd like to thank all the co-moderators and, of course, Nicholas, and all of you for your attention and for staying to the end. Thank you, everybody.